Good afternoon, everyone. Welcome to today's research conference. Sorry for the technical delay there. It's a real pleasure to introduce Christopher Cox, who's an associate professor of medicine in the Division of Pulmonary and Critical Care Medicine. Chris studied his undergrad years down the road at Chapel Hill, and then afterwards went to MUSC for his medical degree, went up to New York for residency, and then came back to Carolina and did a health services fellowship prior to doing his pulmonary critical care training. And since then has risen rapidly through the ranks here at Duke, doing some very interesting work in critical illness and helping patients and families cope with that. He's got some very interesting work funded by PCORI as well as the NIH, and look forward to his presentation today. Thanks.
Awesome, thanks. All right, thank you all so much for coming. These are my conflicts. Are not really conflicts, I suppose. So I just want to tell you a little bit who I am first, because I don't think the pulmonary people come across this side of the road very often. Let me tell you, it being 90-some degrees, right? I'm surprised it didn't have like sweat stains or anything. But I'm a doc. I guess I think of myself as sort of a health services researcher. I'm an ICU doc. I do palliative care also, and I've always been interested in the experience of families and patients who have gone through some pretty tough stuff. And so much of the things that you all do have influenced me as well. And I have this really provocative title for this talk, and it just so happened that a friend of mine gave me this book on sort of the anthropology of natural disasters, Peter Cusin. At the same time, Annika was trying to get me to actually give a title for this talk. So hopefully this will be fun. If there's something that you think is cool or interesting, or you have a question about, please stop me, because talks are just, they're dull if no one interacts, no one has fun with it. So that's what I'll do my best to do. I want to start by saying thanks to the people that helped me. Anything I ever got out of life, it's because I worked with people who were smarter than me. And some of these folks are in this room, some are not. But I really deeply appreciate these folks. We all work together. And we're going to see a little bit from the people whose names are highlighted in red, especially. It's the psych team. And a couple of cool ideas that my friends Amy and Matthew and I have been cooking up lately. So I'm going to make this sort of absurd offering here that when a system is so complex, why not just let the user help you to make the rules about how to fix it? And in so doing, maybe we're going to satisfy their needs and maybe even improve things. So that's our deep thought for the day, which may or may not be true. In all of my talks, which sometimes are good, sometimes they're a little crazy, I use mainly pictures, so we're just going to look at pictures. It's great. It gets better and better. And I'm going to talk a lot about things I have not done, but would like to do. And hopefully that's going to be fun. At the very end, I know this is a clinical trials audience. I will promise I will talk to you about a clinical trial. So, when there is a terrible natural disaster, it's a very complex thing. And I like to think of critical illness in kind of the same way. These people suffer a multi-dimensional trauma. We are all familiar with the physical problems associated with critical illness, but there's cognitive problems, emotional issues, which is what we're going to focus on through the rest of the talk, but also just this amazing ripple effect throughout families, friends, affecting job, kids, finances. Almost half of people lose their entire life savings when they go to the ICU. It's really remarkable. I had to put my little cardiology joke there at the end. But I guess the point is, like, when we're talking about what makes this better, what can we do? And it's so complex. There's not one little thing that's going to make it all better. So how do you think about that? How do you unpack that, and then target your interventions to help? So in a natural disaster, a lot of stuff happens, right? People rush in, we're giving food and shelter, and then fortunately, we also hear the stories of a whole convoy of trucks delivering like canned beans or something like that with no can opener. But nonetheless, we really do our best. The same thing in the ICU. We sort of rush in, there's a problem, there's a hole to fill, right? We just put it all in there, right? We'll give anything that we can think of in the hopes that something's gonna work, right? That's kind of the way we do. But then when the news cycle is over, a couple of weeks go by, we move on. And the same is true for us. We move on to the next disaster, the next person that needs some sort of life support or whatnot. And perhaps this is not the worst recipe for success. Look at the remarkable difference in sepsis mortality that's occurred over the last 10, 15 years. It used to be 50%, and at our latest big research meeting, there was a study out of New Zealand that showed their mortality for septic shock was 18%. It's remarkable. You name it, and we've made the mortality better. With an interesting phenomenon that is we start to squeeze the balloon and people move from conditions they used to die from to conditions that they're now surviving, we are seeing other problems. And you may say, well, those are good problems to have. You're alive, right? But in this day and age of cost concerns, these are resource utilization issues, but also now we're seeing a new population, hundreds of thousands of people with depression, terrible anxiety, PTSD, and whatnot. So what do you do? Let me explode that psychological distress piece out a little bit. I know there are a lot of folks here that are interested in this. Well, it turns out that the folks we see in the ICU who survive 1 year, we're a clinically meaningful burden of depression, anxiety, and PTSD. It's almost half of people. It's truly remarkable. And you can think of lots of reasons why that may be so. And interestingly, for the family members, same exact rates of psychological distress. Remarkable. So here's problem number one. Like, this is me, and this is what I see, right? After you go through those doors, I don't know what happens to you. Well, I do, because I've called these people for so many years, but I think a lot of us, we have this sort of limited view. And if it doesn't happen in a way that we can see it easily, then perhaps it doesn't happen at all. Like, does a tree make a sound or whatever? So let me tell you 3 quick stories. These are, if I could boil it down to the 3 stories I've heard the most from these people. Number 1, the classic is, hey, you were on life support machine. In follow-up, I'm sitting there, the primary care doc says, hey, it looks fine. What's the big deal, right? You had terrible ARDS. I don't know. It's all better now. You should feel better. Story number 2 is the person, when they complain about this, that, and the other, they say, well, you should be happy to be alive, which is true, I suppose, but perhaps that's not what the patient is wanting to hear. And number 3 is, you know what, it's going to get better. And in fact, that's not true. A lot of the time, that is not the case at all. In fact, there can be recovery, but many times, as Margaret Herridge has shown in physical function in critical illness survivors, you often get about 70% of what you were before. These are young, healthy folks with a terrible illness, ARDS, which is like a terrible inflammatory condition of the lungs, and you're on the life support machine. And we've also shown that 1 year you're still having terrible depression. So again, that's not exactly true. So what is the current approach? It really has to be pretty bad before people sort of zero in on these symptoms to help folks. You like these graphics? They're pretty high tech, aren't they? There are some fancy ones, but I'll tell you, I just had this awful week with this one study, and we were here all through the weekend and whatnot with our database. So I apologize, I'm a little scattered. So this is what we have. What makes it even tougher, which is sort of speaking to the second problem. When these folks who go to all these different places are being cared for with site-based care, they completely speak different languages. We describe things in different ways. Our data systems don't talk to each other. Pain in one place is probably measured differently than another. And the end result is like the patient ends up hearing some sort of like African click language or something, right? That was pretty sharp there. But the reality is that people they tell you, I feel bad. And they have really basic questions. What do I expect? Is this normal? Actually norming the situation, this is half of, I think, what people want to hear. Is what I'm feeling okay? Do other people feel like this? And they just don't have this information, and we're so bad at providing it to them. Oops. Just making sure you're awake. So here's a reality check. So how do we begin to tackle this complex situation? There's so many different ways to go about it. There's so many different problems, and they range from technological to interpersonal communication to really even knowing what is important to people, what's on their mind. How are they prioritizing this list of 10 different issues? And just the sheer complexity of their different health trajectories. And there we are, there's the doc and the patient together being struck by the lightning of reality. This is the last little detour I'll take, and then we'll get back to the point. But this is a study that I did with a fellow a few years back, which I think is remarkable. First of all, because it involved no fancy statistical modeling, and it ended up being kind of impactful. So if you can imagine a cohort of ICU survivors, say like we had 125 folks that we followed over the course of a year, we knew where they were every day of the year. And if you were to break that down and draw circles that are equivalent in area to the amount of time the whole cohort spent in that location over the course of the year, this is what you'd see. So that's not the interesting part. Well, I guess it is. This is the interesting part. So just speaking to the complexity of working with this patient population, each of these lines here is actually a path that a patient took between one disposition and the other. Let me give a close-up. So between the LTAC and the hospital, there's probably, I don't know, like 50 different trips. And if you kind of summed it all up together, almost 500 different trips between these locations that this small group of patients took. So, sort of mini summary number one. I don't want it to come across like the docs, the clinicians are bad or they're unfeeling. I think that's totally not the case. In fact, the people across the street, they're fabulous. They really care so much. Yet, point number one is that myself, being sort of a first responder in the ICU, we have a limited vision of what it is people actually experience. Number two, it's hard for us to hear their stories and to respond to them. It's really hard for all the reasons that we outlined in my crappy slides. Number three, so for the secondary responders, for the people who are out there in the community, notably the primary care providers, for them to kind of give the people what they need, that's a tall order given the limitations of the system. Okay, so let's talk about the more interesting stuff. So what do we need exactly? I think we need a way for people to tell their story, very simply. That story may be pain, maybe about breathlessness, depression, which is kind of our particular interest. I don't know, but it needs to be given to them in a way that's easily said and easily understood. And I think the therapies we do have to be really collaborative, which we'll see in a bit. And hopefully, if we can make these a user-driven type of flavor, that's going to be the way to go. So where's this going? We're going to talk about two things: user-driven interventions and user-informed decision-making, maybe at the very end. So this is an idea that myself and Amy Abernethy and Matthew Harker are kind of working on at the moment. So we'll try to walk through this in this very kindergarten-y way, and then I'll show you a fancy graphic about it. So in bit number one, the patient may have some problem. It may be depression, anxiety, whatever it is. They are able to sort of tell their story, that is, to enter this data somehow into number two, some type of data repository, which then informs an intervention, number three there. It directs a researcher to do something, gives them some sort of supportive module or something like that, which these little guys here on the side, which is the patient and the doc, or the researcher and the clinician, can help out with. This is how it might look with depression. So imagine these folks, these ICU survivors, are suffering from terrible symptoms of depression. Using something like patient-reported outcomes measures or a clinical encounter, this information is put into a database where we can all actually use it. It sort of speaks the same language. And then we can apply some rules to translate it into real tasks that can help real people. For instance, these tools, which are here at the bottom, could be support interventions, like the coping skills thing I'm going to talk about. Could be decision aids, which is our other big target area, which we're really excited about, as well as any host of other tools, like, for instance, for all of us in this room, trying to track down these people to enroll them in clinical trials is a real challenge. Let me just start with this bit on patient-reported outcomes, which we're infusing in all of our trials, which is kind of interesting. And I'm going to bring up a kind of an ethical quandary about that in just a minute, which we've run into. So here, imagine this is depression. There's 3 different patients, and they're kind of entering in their depression scale scores there: the green patient, the blue, and the red. And we can very easily turn these into trajectories, which are kind of helpful. But what could be really cool is if you as the doc could see your patient population in terms of who's in the red zone, where their depression symptoms are really bad, who's in the target zone, and who needs a little bit more work. For instance, this person in green here, isolating someone whose trajectory is going in a concerning direction. Maybe this is the way to better target people for our clinical trials. Certainly, we are scratching our heads over that one as well. Or imagine looking at it like this. If I was the patient, you sure would like to know, how do I compare to other people? And I recognize there are a couple of websites that let people do this. But for docs and patients alike to see these things and perhaps act on them differently, I think that it's a really cool potential way to manage the health of populations using kind of individual person's data points. And perhaps, again, screen for clinical studies. So again, back to the case of the intensive care unit, which this is actually the situation we're in so commonly, right? They have like 10 different things going wrong. So what do you do? How do you even break this off? And then I think our answer is probably C, starting by asking, what's the most pressing matter that we can help you out with? And again, I hope I've given you the sense that the complexity of the people that we're dealing with is just really kind of unparalleled. And that's why we're moving towards this simpler, user-driven approach. I actually made a haiku of this. So this is, that's pretty good. It's very New York of me, isn't it? This is the first sketch that we had as we were sitting there kind of roughing out some of these ideas. So here you can see, even though you can't read my writing, there's a host of issues. There's physical problems, functional, social, psych, you name it. The idea would be is that you can apply, as a patient, different filters, and you can help prioritize your own problems. You also can rate your abilities or the severity of these sorts of things. Here's the problems you isolate. You get to rate and prioritize them. And then at the end, you get a couple of things out of that push you on into the intervention. This is how this might look. If you could imagine, now we've kind of isolated the problem as, say, depression, anxiety, PTSD, or whatnot. We can actually use this sort of user interface to match it to a person's sort of profile. I realize this is a bit hard to read. Let me walk you through this. For instance, there could be the high-powered, busy person who nonetheless is very engaged, has high health literacy, very tech-savvy. They may be very much focused on convenience, perhaps more than interpersonal interactions. They may want video versions of different things, coping skills, mindfulness, all sorts of things we're doing right now. You have the young, crunchy Whole Foods worker who's totally into mindfulness, of course, right? And then here's perhaps an engaged, flexible person who wants a telephone-based intervention. Or perhaps the leave me alone, Montana resident who just wants to perhaps take their medication and be left in their compound. So we're just doing a little small slice of that, right? So we have an intervention which is a telephone and video-based intervention for depression. We take all these ICU people, we identify people at risk, we apply our intervention, which has a lot of different nuances or flavors, I guess, and then there's a nice feedback loop where we use profiling and electronic patient-reported outcomes to keep tailoring, fine-tuning the intervention for people. So there's a structure, but yet there's a way where we just distill the successes into a tasty bite. So this is it. So with the world's longest wind-up, this is a randomized trial we're doing right now. We're about halfway through enrollment, and we are comparing a coping skills training intervention delivered by phone and video to a sort of control-ish education program, also delivered by phone and video. This is the sort of messaging we use for patients. We have very simplistic text web-based messaging. We try to, really keep it simple. You see very quickly, we're working on anxiety, depression, and PTSD, and we show exactly what we're going to do, who can be in the study, and try to push people towards our website. This has been really effective, by the way, and we also have like kind of infomercials that are about a minute and a half long, where we show people in the hospital, kind of give them a flavor of the study. It's really been, we've gotten good feedback on that. And this is how we think it might work. We're trying to increase adaptive coping and self-efficacy to reduce the psychological distress. We're also focusing on some novel outcomes because it's what people told us was sort of important to them, like days at home and quality adjusted days at home. Oh yeah, let's see here.
Are you going to Are these all ICU discharges?
Yeah.
Or?
Let me back it up. So who can be in the study? Any patient who is on life support for at least 2 days, and they get to choose they get to phone a friend, I guess. They get one person who will be their caregiver, helper, I guess. So that's a pretty wide. Actually, you raise a good point. Who do you put in the study? It's a great question. We have no idea. Let me back that up a little bit. Here are the competing issues we have. On one hand, you want people who are sick enough that can benefit from a therapy. Yet on the other hand, if they're too sick, if they have cognitive issues, if they are destined to languish in nursing homes, LTACs, rehabs for the next 4 months, clearly that's going to be a population that is probably less likely to benefit. So where's the sweet spot? And that's hard to know. So we're trying to figure that out. We're trying to do a study, use our intuition and the medical literature to best sort of inform that. It's hard. You immediately have to, for instance, exclude, for the most part, homeless people. It is heartbreaking to talk like that, but if you don't have a phone and you don't have, we can't reach out to you right now. So we've had to make some really tough calls, and it's just, it doesn't make me feel good, but this is the reality. We feel like we've got a series of exclusions that are realistic. They're not overly harsh, but it's a great question. Actually, a follow-up question to that may be, okay, well, how many people are staying in your study? What's been your success so far? We're seeing probably between 25 to 30% of people dropping out or dying before they complete the intervention, which is about what we expected. It is really hard to predict I think who those folks are. I've not looked at the data, I just know the sort of raw cut of that. So I think, through doing the study, we're going to learn perhaps the most valuable lesson, which is what type of person do we need to target our resources toward? It's a great question. We argued about this for like 2 months, and no one agreed on this. So I just wanted to say that actually, believe it or not, this study is based on some sort of evidence. And when we piloted this intervention before, we were actually able to show a pretty substantial drop in depression and anxiety scores, as well as PTSD scores, which are sort of noted by the PTSS. And the sort of mechanistic pieces of the intervention, the self-efficacy and the coping also were increased. I would show you a couple of cool things on the website, but I just realized that I'm not using my own computer. I was going to show you the patient-reported outcomes piece. But just sort of in closing, I wanted to actually talk about some of the difficulties we've had with the study. And some of them, I guess, are in the ethical realm. And others have to do with just the problems associated with doing a multi-center study with multiple time zones and whatnot. So I don't know if you all recall seeing this in JAMA. I think it was maybe at the end of last year. And the interesting thing, like patient-reported outcomes, so awesome, so great, we all love them. But as you're doing a clinical trial, when you have electronic databases, and like with our trials, people are entering their own data into little iPads, or the research coordinator is doing it in real time, or they're at home doing it. And so we know their depression and anxiety and PTSD scores in real time. Before, you just did the study and you kind of unlocked things at the end of that time, and kind of wrestled with that. Now we know in real time when people's scores are totally off the chart. Like, what do you do with that? It's a really great question. And I don't know, has anyone ever been in that position? Well, let me tell you how we decided to take that on. And I'm curious to hear your feedback about how successful or how smart this was. We actually have, they're scored within the data system. Our database, our entry, user interfacing, it's all the same. So imagine you fill out your depression scale and it's really super high. It's like crazy high. The data system sends me and my research coordinator an email saying, you know, ID so-and-so has a score of whatever on the PTSD scale. So cool, we patted ourselves on the back over that. We thought that was really great. But then what do you do with that? There are many studies we conduct where people have these very high symptom scores, and as the coordinators are interacting with them, if they don't really get the sense that someone's suicidal or whatnot, what do you do? So we sort of tried to use the medical literature to give us its best insight on what were really severe levels of these symptoms. And I just started calling people to check on them to make sure they were okay. We also were able to give people a list of resources near their sites for them to take on, to take this therapy a bit further. If they requested to be referred to a therapist or psychiatrist, you know, we're certainly prepared to do that. Interestingly, I would say that at least half of people in our study, for their first questionnaire, they were all above these really high levels of symptoms. So very quickly, we were overwhelmed. And I called a lot of folks. And it turns out not a single person ever visited an emergency therapist, ever called the helpline. No one acted on this at all. This became a very interesting issue, because it was taking a ton of our resources. It was taking a ton of research coordinator time. It was taking a lot of my time, which is perhaps not the most important thing. But nonetheless, we figured we should put this back in the box because this is not, it doesn't seem to be doing anything. So we had a really interesting discussion with the IRB about how do you put it back in the box? And how do you do that in a way that, like we just wanted to be above ground, right? We wanted to do the right thing, and we thought we were doing the right thing. And we ended up sort of being able to do that. But it was a really fascinating thing. Like, as we get more and more information and data, some of which is a little bit scary, what you do with that is a great question. I just wondered, has anyone ever had such issues in any studies or trials that they've done? Run across that yet? Well, I think we all will. Oh yeah, go. Do you have any?
With the call center, and we use the Duke IRB, so there is a script, and we have to then refer that patient even on, you know how you call sometimes for an appointment, and said it's an emergency, you call 911?
Yeah.
So it does, and then we also have to be very careful on the question that we're asking, because we can't provide a resource. So some questions we can't ask if we can't then provide an immediate referral mechanism.
Yep.
And that's what the Duke IRB was telling us. So there is a printed script that the call interviews have that they have to say to a patient if the patient out of the blue says they're going to commit suicide or they're going to go do something.
Yeah.
So what did the Duke IRB say to you?
Yeah, no, they were, we have some of the most experienced coordinators who actually have histories of doing personal therapy and all this. So they're really a unique group. Nonetheless, you know, it's what is written is written. They were okay with us kind of packing this back in the box, believe it or not. Though we had to sort of make the case that this was not helping anyone. No one was utilizing this. Certainly, should someone be suicidal or whatnot, absolutely, we're on that. But in hindsight, it would have been nice to include a question around suicidality. Unfortunately, these questionnaires do not have, the ones we chose, do not have that specific issue, which makes it so much easier. Note to self, but it's sort of a fascinating thing. Here's exactly what we saw. We get these emails. Everything's been grayed out. There's no PHI here. And this is what we'll see. And we get this and we act on it immediately. It's kind of interesting to see what the potential possibilities are for this health data as it comes to you in your study. But again, the danger being is that the more I know what's going on in the study, the greater the hazard is that I sort of inject my bias, or my coordinator, even worse, because they're closer to the data, they start to sort of subconsciously tweak this, that, and the other. So again, it's an interesting tension there, I think. But just thought you'd think that was sort of interesting. And then lastly, as we've had all of this data swirling around, I just wanted to, sometimes it's fun to complain, so I just wanted to spend a couple minutes complaining about, we're so thankful and we're so happy to be able to do this study because we really believe in our patients, and I think we're really trying our best. On the other hand, it is so hard to work with this patient population across 4 different sites, and we enroll people in the hospital. We're not sure if they're going to go home yet or not. So we have to track them down after they leave the hospital, and they have to get home within a certain amount of time. So imagine you're out in Seattle. The site coordinator has to enroll them, keep tabs on them. They may go to a nursing home for a month or 2. If you can get home by 2 months, you're good. Then they have to hand that information back off to us. We have to track them down and interview them. What do you think the likelihood, if you're living in Seattle and someone calls you a month after you leave the hospital and they have a 919 area code, what do you think the likelihood that you'll answer that call is? Actually, this was very funny. I was just sort of like pissed about this because, no one was answering our calls, and, we wanted so much to help people, and I was walking somewhere, and then someone called me, and it was like some Indiana telephone, and I just hung up immediately. I was like, who's this calling me from Indiana? It turns out it was this friend of mine. And then I realized this is so deeply hardwired in our psyche that, if I don't know you, if you're not my friend, if you're not on my Facebook or whatever, talk to the hand. So we've had to become extremely creative and facile with texting and emailing, and you name it. We spend a ton of time creating these fancy emails with links to our ePro system and whatnot. And I've spent lots of time printing stuff up and having really good scripting and handoffs between all of these different people. It's still just been really, it's hard to do this study. It's really hard. And perhaps we are struggling with how best to convey the sense of what the value proposition is to the participant. We're sort of working on that messaging a bit too. And I think it's something, of course, we all struggle, engagement, retention, and whatnot. But when you're dealing with a bunch of fairly, some people are in some of the worst social, economic situations you could imagine, which is what got them into trouble in the first place. And to begin to kind of interact with them on their own terms, it's tough. We're just learning the language, I think. So I know you can't read this. It's not intended to be read. This is a timeline of our study, and the different paragraphs show different types of things we've done to counteract some other debacle or issue or something. And so you can just see as time goes on, we're doing all this programming, you name it. We're trying everything. We even do get on Facebook to track people down. Seriously, it is really. it's a labor of love, I guess. That's like the glass half full. So I don't know if anyone remembers the great Dave Chappelle show. You don't know the end joke. That's a shame. So the end result, this is what we want to do. This is what our whole research operation is focused on. Before, we used to just, so this is me, the dark line, that's the dumb ICU doc. I would just say, okay, they get home, maybe they're there a year later. You know, how bad could it be, right? And then we started to get the sense that, wow, people had some tough times. So if the mortality angle is not the way to push, what we want to do is like kind of push up the quality adjusted portion of that survival, and to try to improve people's sense of well-being and improve the, people call it the state of recovery. That's what we're trying to focus our energy on. So in summary, you know, we have a ton of challenges we're working with. We're idiots. We don't know what we're doing. We have some ideas. We're not sure exactly the best way to apply some ideas which we think are really cool, but we're not exactly sure how best to target these folks. And we're trying to get better and better at letting people sort of drive the intervention, prioritize that. You know, of that sort of big circle, we're this tiny little bit, you know, but we're trying to get there. We're trying not to be overwhelmed by the complexity, but instead focus on areas of simplicity where we can connect with people and collaborate. And it started with thanks. I wanted to end with the same thanks. And I appreciate everyone's patience. If there are any questions, complaints, we can take either.
And can you just roll back a little bit? You were talking about, you got a message about someone who was in the target zone, very depressed, and you had 3 options: a call from the doc, make them aware of resources that were available, or refer them to a professional. Did I understand that correctly?
Oh, yeah, what was that? I don't recall the...
You had set up a system where you would get your team would get an email message?
Yeah.
Okay.
That, yeah, the alert system.
Yes, and if I understood, there were 3 options: a call from you, or they would find out what resources were available, or be referred to a professional. And you said, I think you wound up calling them all?
Yeah, I did. I kind of feel like these people are my family, and I'm blinded to the intervention, but I kind of feel like if a Pittsburgh patient has an alert, like I want to take that off them, and I need to take responsibility for that patient. And so therefore, I of course talk to the site level coordinator and PI to see what's the real story here. And I do call people and just make sure that they're doing okay.
It would seem to me, then I believe you said that nobody took advantage of the other resources. I would think a call from a physician at my home would mean the world to me, and that would certainly talk me off the ledge.
So let me back that up a little bit. I am not making a therapeutic call. I ask a couple of very simple questions about suicidality and about just simple stuff like that. I try very hard not to get into the substance of, you know, kind of the life story. But you may say, well, that's kind of impossible to do, isn't it? And I would say that's probably true. But I'm very mindful that the more contacts we have outside of an intervention, it runs the risk of contaminating that intervention. And perhaps it is a therapeutic phone call, you could say. I tried my very best to be very ornery, very difficult, you know, just sort of a jerk on the call, but still ask them if they're suicidal. Try to use like a, you know, New York accent or something. So, but that's what do you do? I don't know. We do give people in the packet a list of these resources that we mail to them at the onset of the study, actually. But you know, you get a bunch of stuff in the mail. You know, who reads the fine print, right? So, yeah.
2 comments. One, as a past ICU nurse, I applaud you for even taking this on. We've watched
Well, you didn't
for
say
years.
you were offended.
Way to go. keep that glass half full. And as a mom of an 8-year-old, I loved your cartoon slides. Those were fantastic. My 2 questions. One, you mentioned you have 4 or 5 sites. Where are they besides here?
Yeah.
Is one question.
So this is, gosh, if I could do it again. So it turns out that there's a site in Seattle, University of Washington, UNC, our good friends down the road, and Pittsburgh. And we also enroll out of Durham Regional and Duke. The nice thing about Seattle is that you get to go on site visits, but the bad thing is that when your intervention is calling people.
Yeah, the time zone.
Just didn't think that one through so well. So my hat's off to our coordinators and to the interventionists who are Tammy Summers and Pam Bach. Laura Porter helps out with that, and Sarah Kelleher. They're sometimes calling these people at night.
After hours.
So I have to ply them with occasional 6-packs or whatnot. But they really do a wonderful job. They're so flexible. But it's hard. It's really hard.
And last question, your funding. Do you have funding, and where is it from?
So you're trying to say someone funds you?
No, I believe that.
That's the way I kind of
funded.
interpret
You've got to believe it.
That's okay. I'm not offended. PCORI pays for the coping study, and I certainly have more of a decision making is where we do the majority of our work. I'm really into web-based decision tools and collaborative tools, which I didn't talk about because I don't know, just felt like talking about something a little bit wacky, but that's from NIH. So, and DTRI is DTRI and DCRI. It's just the same acronym. I should probably know this. They gave us a little bit of money to help build out a PRO for one of our databases, which is really awesome, and hats off to them. I appreciate it.
Thank you.
Yeah. All right. Well, thanks so much for coming out. And sorry if it was a little scattershot, but like I said, it's been a tough week. But thank you so much. Have a good day.